Today we're presenting the improved phase results for our process improvement project focused on reducing patient no-show rates in the outpatient psychiatric clinic at XYZ Hospital. The improvement team worked through the define, measure, and analyze phases to identify the main drivers behind missed appointments and then designed and tested targeted process improvements to address those causes. In this presentation, we will walk through the key improvement actions that were piloted, the database results, and the final solution selections. We will also review the improved tollgate outcome and confirm readiness to move forward into the control phase. A no-show rate occurs when a patient fails to attend a scheduled appointment without canceling in advance. In an outpatient psychiatric clinic, no-shows reduce patient access to care and result in valuable provider time going unused. They also create scheduling inefficiencies and can increase wait times for other patients who are trying to get appointments. During the analyze phase, the team reviewed historical appointment data to better understand the key drivers behind the high no-show rate. From that analysis, the team identified two critical drivers of no-shows, referred to as critical X's. The first critical X was patient age combined with appointment time. As shown in the table on the left, patients under 30 years old who were scheduled for morning appointments had a significantly higher no-show rate than other patient groups. This suggested that time of day scheduling patterns were not equally effective across age segments and that younger patients may have more difficulty attending morning appointments. The second critical X was whether or not patients received a reminder call before their appointment. Patients who received a reminder were much more likely to attend their visit than those who did not receive a reminder. This can be seen in the table on the right, where no-show rates are noticeably lower when a reminder was provided. These findings showed that both scheduling practices and reminder processes were directly contributing to the high no-show rate and gave the team a clear, data-based direction for their improvement efforts. Based on the critical X's identified during the analyze phase, the team explored several improvement options using a combination of brainstorming and benchmarking. Brainstorming focuses on creating new ideas based on the team's process knowledge and experience, while benchmarking looks at solutions that have already worked well in similar organizations. For appointment timing, the data showed that younger patients had a higher no-show rate for morning appointments. The team brainstormed ways to adjust the scheduling workflow and identified an opportunity to prioritize afternoon appointment slots for patients under 30 years old when possible. For appointment reminders, the team benchmarked several commonly used approaches at other organizations. This included staff reminder calls, automated reminder calls, email reminders, and text reminders. Since the options differed in expected impact and practicality, the team decided to use a structured comparison approach to decide which solution made the most sense moving forward. To select the most effective reminder solution, the team used a weighted decision matrix to evaluate the possible options. Each option was assessed using the 4 criteria: its impact on reducing no-show rates, the amount of staff effort required, the cost, and the ease of implementation. Weighting these criteria helped ensure that the final decision was both effective and sustainable. While staff reminder calls were effective, they required significant ongoing labor and were difficult to sustain long-term. Email and text reminders were also considered, but were less reliable because not all patients regularly check email, and text messaging is not consistently used by older patients. Automated reminder calls achieved the highest overall score because they provided strong performance across all criteria. They reduced no-shows, required minimal staff involvement, and offered a positive return on investment. Based on this analysis, the team selected automated reminder calls to be placed 48 hours before appointments. In addition, the team also implemented a scheduling process adjustment to prioritize afternoon appointments for patients under 30 years old. The team conducted a 3-week pilot test to evaluate the revised scheduling and reminder processes. The pilot included scheduler and registration staff and tested 2 main changes: prioritizing afternoon appointments for patients under 30 when possible, and adding automated reminder calls 48 hours before each appointment. Before the pilot began, the team put a communication and training plan in place so that staff understood the updated workflow and how the revised process should be followed. The FMEA identified key risks and the actions taken to reduce them. One risk was that patient age might not be considered during scheduling. Adding an automatic EMR alert for patients under 30 greatly reduced the chance of that failure occurring and reduced the overall RPN by about 8-fold. Another risk was that patient phone numbers might be outdated, which would make reminder calls ineffective. Adding a step to confirm contact information reduced both severity and occurrence ratings and lowered the overall RPN by more than 4-fold. The pilot results showed a clear improvement in performance. The average no-show rate decreased from 24.71% to 8.44%, demonstrating a meaningful shift in the process outcome. Ownership for the updated steps is defined in the future state flowchart. Schedulers are responsible for responding to the age alert and prioritizing afternoon appointments when appropriate. The clinic coordinator is responsible for ensuring the automated reminder calls are scheduled and sent 48 hours before appointments. At the conclusion of the improve phase, the team conducted a tollgate review with the process owner, project champion, and the broader project team. The pilot results showed a meaningful reduction in no-show rates, which satisfied both the CEO and the process owner, and they formally approved moving forward to the control phase. During the review, the CFO recommended that the financial impact be more formally quantified during the control phase. To support this, the team will gather ongoing financial performance data and compare it with appointment volume and no-show rates under the new process. Based on the strong pilot results and leadership approval, the team is now prepared to move into full-scale implementation as part of the control phase. Thank you for your time and attention.